Our next speaker, we've had to make a slight alteration. Ritz was supposed to talk, but she's having difficulty to reach us. So Professor Andrea Danese has agreed to step in on this slot. And for us, I think Andrea is probably the only external speaker that we've invited today, probably because we are so interested in the kind of work that he does, in particular with children and adolescents who've been traumatized. So we would like to have you on our group one day. Andrea, please welcome Andrea. Thank you.
All right, everyone. So I'm so pleased to be here and to, in some ways or another, really join the family. So first of all, happy birthday to the Center for Global Mental Health. And thank you for inviting me here. I come here as a vocal advocate for child and adolescent mental health globally, rather than an expert in global child and adolescent mental health. That's an important distinction that I hope we will cover and address over the next 10 years of work and research. So much so that I was actually taken aback and I had to think twice before accepting the kind invitation from Ricardo today. But I thought to still be here with you for a couple of reasons. The first one is that I am fully aware that it has been very challenging for experts and researchers in global mental health to really build bridges with basic and clinical researchers like myself. And so I really wanted to take the opportunity to think ahead. The second reason is that I really realized that my own research has been brought forward by interest in global mental health. Indeed, I started really thinking about getting into research when I was back in Italy, where I trained in medicine. And back at that time, the Yugoslav war were going on. They were happening, and were having incredible impact on the life of so many people, and particularly young people in those areas. Many of them migrated to Italy. And as I started working as a doctor, and I served for my social service job after graduation, I really started working with young people who were coming from those areas. And it was really working with them, understanding how brave and resilient they were in many cases, and how vulnerable they might have been in some other cases. And looking at the complexity of the mental health presentation that they were coming with. Really, that was one of the main triggers that started my interest in mental health and convinced me to take a big step and come from Italy to the UK to train, both in research, that's where I had my PhD at the Institute of Psychiatry, and also changing in many ways the training that I was going to do. And after training in adult psychiatry, I decided to also train in child and adolescent mental health. So what I will try to do today is, first of all, to explain why I was, and I still am, so excited about child and adolescent mental health. I think we should all be. I would like to tell you a little bit about our research and how this research, I think, might have, perhaps in the future, great impact on the development of the field. And finally, putting some challenges ahead that I hope we will be able to address in the future. So to begin with, I tried to rephrase a very important sentence that appeared at the beginning of this area of work. Of course, in a very important Lancet publication, it was put forward by Vikram, Martin, and others, that there is no health without mental health and without global mental health. I also think that there can be no global mental health without paying very careful attention to child and adolescent mental health specifically. And I want to share with you some ideas on this. The first, very obvious point to make here is that in many cases, psychopathology has onset in childhood years. Many studies have shown this, and I'll just mention a couple of them. First of all, in 2003, in the Danese multidisciplinary health and development study, one of the cohorts that I'm lucky to work with at present, it was reported that of the cases of psychopathology at age 26, a very large majority was to be found in childhood and adolescent years. So what you can see on the left-hand side is that 50% of the cases of psychopathology at age 26 had a first diagnosis between age 11 and 15. And this is focusing on age 11, 15 simply because that's when we started actually assessing psychopathology in this long-term cohort. And you see that about another quarter, 23.9%, had the first diagnosis by age 18. So all in all, 75% of the cases of psychopathology identifiable at age 26 had onset in childhood and adolescent years. Now, this is thinking about psychopathology in general, and in other studies, we had even greater resolution to look at diagnosis more specifically. So this is often cited finding from work from Bronk-Kessler and others. And what you can see here is that at the bottom, we have, again, that the onset of any mental illness is around age 14 to 15. And this really highlights that the onset of most diagnoses, not only ADHD and conduct disorder that are often thought of, so neurodevelopmental and behavioral disorder, to have onset in childhood, but really most diagnoses have onset in childhood and adolescent years, particularly anxiety disorders, but also mood disorders, and also schizophrenia and substance use disorder. So the first reason really to really pay close attention to child and adolescent mental health is that psychopathology and mental health issues really have onset in those years. And if we can do a very good job in those years, either in preventing or in addressing early on those difficulties, we might be able to prevent a large burden of disease later on. The second reason why it is so important to pay attention to child and adolescent mental health is that psychopathology at that age is predicting a subtype of psychopathology that is accounting for most of the burden of disease. What I mean by that is that children and adolescents who develop depression, for example, are more likely than those who do not to experience high rate of suicide, risk for increased risk of major depression later on, and increased occurrence of psychiatric and medical hospitalization, as well as impaired functioning in work, social, and family life. So what is important here is that the early onset of psychopathology that we have seen occurs often identifies a subgroup of those who will have psychopathology in their lives, a subgroup that has a peculiar recurrent and treatment-resistant type of psychopathology. This is important if we look back at the basic epidemiology of depression. And by it, I just mean simply to look at the prevalence of depression. On the left-hand side, you see the 12-month prevalence of depression, and on the right-hand side, the lifetime prevalence of depression. What you see on the left-hand side, so the 12-month prevalence, is that the prevalence of depression varies between 10 and 17%, whereas the lifetime prevalence tends to vary between 10 and 40%. So this tells us that the lifetime prevalence of depression is only 4 times as much as the yearly prevalence of depression. So the two are not independent. This basic epidemiological evidence tells us that, again, the lifetime prevalence of depression is accounted for by a subset of those who experience 12-month prevalence of depression and go on and develop multiple recurrent chronic treatment-resistant forms of depression. We just said that these kinds of episodes of depression really identifies those who start early in life to experience depression. And so the second reason why we want to pay close attention to child and adolescent mental health is that by working early, not only we could prevent the incidence of depression later in life, but we can also work with that most vulnerable population who will develop recurrent episodes. And therefore, perhaps we can address that burden of disease that is at its highest in young people. Now, what I described so far really addresses, if you like, life course concerns that start early in life. But we don't need to wait until adult life before seeing that mental health illness is impairing and risky in young people. In fact, we can look at, for example, DALYs, so disability-adjusted life years, which is, of course, a key measure of disease burden. We can see how this is distributed over the ages, different ages. So here on the bottom, on the x-axis, you have the distribution of ages. And what you can see is that the distribution of DALYs is not only important in adults, but is also very important in children and adolescents. Now, you will see that this increase in DALYs that is most significant is not even for those neurodevelopmental and behavioral disorders that we often think about, but is really accounted for by the onset and the impairing effects of depression and anxiety disorders. This is what you can see here. Now, why that might be the case? Of course, when we measure disability in adults, we think about how much they can work and they can produce, they can earn money. In children, though, there are other and equally important functions that are critical at that age. And that is the ability to engage in education, to engage in socialization, and through this to really build at a critical developmental point the abilities that will then enable them to both contribute to society and to live satisfying lives. So we don't need to wait until adult life to think about the disability of mental illness, but the disability of mental illness is really already very important at those childhood, adolescent years. In addition to the disability, we must realize that mortality related to mental illness is already very important in children and adolescents. In fact, is perhaps most important at this age range. You see here that the proportion, the risk of self-inflicted injuries is the second cause of death in this age range. Because, of course, young people are normally healthier than adults, and therefore the impact in terms of mortality of self-injuries is much greater, and it accounts for a significant proportion of the mortality. If we move ahead, we also need to think that young people are the people who are providing financial support for older people. And we know that we are living an epidemiological transition where young people increasingly will have to support older people. The aging population globally is reflected by the needs of young people to be not only to be productive and to support the aging population. So what we have here is an index of the old age dependency ratio. So what we have on the top is the number of population, individuals who are age 60 or older, and in the denominator you have the number of people who are below that age. What we're seeing increasingly is that the old age dependency ratio is increasing globally. This is already an incredible issue in higher income countries, but is quickly becoming an important issue in low and middle income countries. And therefore is also important to think about child and adolescent mental health, because we need those young people, those young adults and adults to be productive members of society so that the economy of those countries can continue to prosper. Now, because of all these reasons, we see that the investment is important, and it's important to also know that the investment is likely to be cost-effective when it's given early in life. This is a model that is often presented from the work of Jim Heckman, a Nobel laureate for economics, that shows just how much the rates of return to human capital investment in this case are greater and more impactful when delivered earlier in life. In this specific model, you see age on the x-axis and rates of return to human capital on the y. And really the focus here was, as it was originally developed, on schooling, showing that preschool programs have greater return than schooling or job training opportunities later in life. But this model has been applied and has been shown to be relevant very much into the mental health sphere. And it's important to consider that not only child and adolescent mental health is important because of all the reasons I mentioned, but crucially that its investment, in child and adolescent mental health may also be delivering very positive rates of return because it targets those vulnerabilities early in life. So it's not surprising then that, as we have already mentioned, WHO with the AIM-Age gap really has focused not only on adults' mental health conditions, but also on developmental and behavioral disorders in children and adolescents. Now, I will argue, given what I just told you, that this is probably just the tip of the iceberg when we think about child and adolescent mental health, and that in addition to really considering how to address neurodevelopmental and behavioral disorders in children and adolescents, we also need to think about how much all these other conditions that are considered in AIM-Age gap are onsetting in children and adolescents. And therefore it's important to develop knowledge about both the assessment and treatment of these conditions in children and adolescents. Now, as important as it is, we of course need to make a reflection on what is the state of the art. And we can look at it in terms of global investment in child and adolescent mental health. And what we're seeing here is really an indication of global developmental assistance in child and adolescent mental health per capita. And you can see that the Global South has a very low investment in child and adolescent mental health. At times, no investment at all, and very often, very minimal levels of investment. So the scale of the issues that we have just discussed based on the known epidemiological evidence is not really matched by the current investment in child and adolescent mental health. And therefore, we need to be vocal advocate for child and adolescent mental health to really highlight the needs of young people. We can also look at research. Although we know that about 90% of young people live in low and middle income country compared to a 10% living in high and middle income country, this distribution is inverted if we look at the amount of research that has involved these countries. So we see that perhaps 90% of research really is focused in high income countries, and only 10% of research, if we look at RCTs, is undertaken in low and middle income countries. So in addition to investment, it's really important that we feel agency and we put forward ideas to develop research in low and middle income countries with regard to child and adolescent mental health. Now, what we have discussed is how important is the mental health of children and adolescents. And I wish I was here to tell you that those difficult experiences that I had witnessed as a young doctor are addressed, that we don't need to worry about them anymore. The reality, of course, is quite the opposite. We know that there are millions of people that are currently displaced. Many of them are young people, and based on the estimate available, the UN has stated that the child refugee crisis in 2019, just this year, is the worst since the Second World War. So this really is highlighting not only the general need of children and adolescents, but particularly the needs of a subset, a very large subset of young people who live around the world. And the issue here, of course, is not just that they are displaced, but with that, we have to assume that they will have been exposed to important traumatic experiences that, of course, are a major risk factor for psychopathology, that they have been deprived of normative developmental experiences such as play, such as education, socialization, that, as we said, are crucial to build young humans into satisfied adults. We know that they would have suffered separation from their parents, again, a key risk factor for psychopathology. And finally, and crucially, they keep being, we just heard, at risk of discrimination, also at exploitation and further violence. So this is true for refugee children, millions of refugee children around the world. But they are by no means the only subset of the population of young people who are at risk of mental health problems. In addition to displacement because of violence, we know that there are millions of adults who are financial, economic migrants. And just recently, Kelly Rose Clark and colleagues have highlighted how much this condition is an important risk factor for psychopathology as well, showing that left behind children are at greater risk of depression and anxiety as well as suicidal ideation. So even beyond the obvious risks of refugee children, we need to think about how global dynamics are shaping patterns of risks for young people, even in their own countries. Now, what I'm, of course, highlighting is the role of childhood trauma as a risk factor for psychopathology. And I wanted to mention a couple of findings from our team that really highlight, in many ways, this effect. In addition to the obvious impact on risk for PTSD, what child trauma does is really a pleiotropic effect on any type of psychopathology and many types of risks. So let me just walk you through these plots. What you have here is a spider plot that highlights the risk in odds ratios, where you have 0, so no risk at the center, and increasing levels of risk as you go outside. What you see in green is the risk simply related to trauma. And what you see is that the trauma is associated with increase in any type of psychopathology, not just PTSD. So major depression, generalized anxiety, psychotic symptoms, ADHD, conduct disorder, and many others. In addition to the risk of psychopathology, we also know that traumatized children are at high risk of self-harm, very high risk of suicide attempts compared to the general population, but also violent offense. They are not in education, employment, or training in high-income countries, but likely also low and middle-income countries. They are socially isolated, and they report loneliness. So these are findings from the UK And I wish in the next 10 years we can better describe and address the needs, not only in the UK, of course, but in many other countries, where children might have even higher rates of trauma than in this country. This is to show that not only childhood trauma is associated with risk of psychopathology, it is also associated with a specific type of psychopathology that is recurrent and persistent. This is a meta-analysis showing in particular that childhood trauma is associated with a double risk of recurrence as well as persistence for mental health problems. It's associated with increased risk of poor treatment response. So in terms of looking for obvious ways of relieving the burden for mental illness, it's important to address these needs of traumatized children. So how are we doing? Well, this is one of the recent meta-analyses looking at the effects of focused psychosocial intervention on the risk of psychopathology. And what you see is that the current interventions seem to have effects on PTSD, but have very limited effects on depression and on anxiety symptoms. Also, if we look at PTSD and we think about the determinants and of the heterogeneity in those effects, we see that the effects is greater for older adolescents, for those adolescents who are in their original village, and for adolescents who are from comparatively small families, which we know is quite unrepresentative to the population we're trying to serve globally. So even for PTSD, where we have some effects, those effects are still quite limited. So this is important because might suggest that in addition to focused psychosocial support, we might want to also think about how to provide clinical services by primary healthcare staff and mental health professionals, because it's important to really identify how these risks related to childhood trauma might be prevented and addressed in the population. And therefore, I hope this highlights the need for interaction between the primary care and mental health professionals, and how this bridge can be strengthened in the future. So I will finish with highlights of a few challenges ahead that I wanted to discuss. The first are related to training, and of course it's obvious, given what we have seen, that it is important that we potentiate training in child and adolescent mental health. As highlighted before, it's also important that we build and we retain local leadership in these countries, and that we scale up local services. These are quite obvious comments, but I think it's important to make them and to focus them on child and adolescent mental health particularly. It's also important that we continue validating measures of psychopathology, we test intervention, and crucially, we build bridges between child and adolescent mental health professionals and global mental health researchers. And these are just two obvious, again, things that I think we will be able to do more of in the future in terms of testing the generalizability of our weird model of mental health in low and middle-income countries, but also how to learn from the great work that has been done in global mental health, to think how models of delivery, training, supervision, task shifting, and IT can actually be brought back and forward between low and middle-income countries and high middle-income countries, as we have more investment, but definitely not enough to address all the needs. So I hope I showed you that child and adolescent mental health continues to be a priority for global mental health, that there are specific populations at risk that need increasing support, and that there are many challenges ahead. In addressing those great challenges, however, we need to highlight that there are huge implications and that success in addressing global mental health needs for children and adolescents might really address important burden of disease across the lifespan. So thank you very much for your attention.
I think we have time for a couple of questions. one here, and then Melanie there.
I'm wearing gloves because it's freezing in here.
Elizabeth.
I'm curious, and this is a very particular question, but I heard someone else also mention, as I'm a person who developed epilepsy as an adult as a result of a brain tumor, and I'm curious to see epilepsy listed as a mental illness. It's neurological.
Yeah, it is.
Why is it, have I seen it twice included as a mental illness on
I think in
slides
some
today?
classification they might put together neurological and mental illness.
Because
Yeah,
I
sorry
don't
about-
see other
I would
neurologic
agree with you.
conditions other than epilepsy
Sure.
listed, and I'm just wondering why.
Yeah, so I agree with you, and I think it's just because in some classification they include both neurological and psychiatric disorder.
Hi, Andrea. It was a
hi.
fabulous talk. I'm Melanie Abbas, Professor in Global Mental Health, and looking forward to our small grant together as well on trauma and young people in Zimbabwe. I wanted to ask you a very genuine question. I have a lot of young students, early career researchers, who want to get into child and adolescent mental health. But they get caught in the chicken and egg. You know, should we start with parenting interventions? Should we start with some of what I think of the really low-hanging fruit, like ADHD? I mean, there is no treatment going on for ADHD in most low-income countries. And the lady who's brought up epilepsy, massively neglected. Or do we start, you know, doing child programs for building social and emotional learning in schools? What's your take on where the young researchers of today should be building their child mental health careers?
Yeah, thanks for that simple question, Melanie. It really, I would say, depends on the question that they want to address. So a question of treatment of mental health conditions is perhaps best addressed thinking about what works for these conditions. And we have very good evidence that for some mental health disorder, interventions based on parenting are effective. But for treatment of other conditions is not the form of intervention that is best to put forward. So I'm thinking, for example, if we think about PTSD or if we think about depression or anxiety, parenting has a role, but we know from evidence in this country and in other high-income countries that there are much better targeted treatment that have been adopted or are being adopted that are likely to have stronger results and outcomes. I don't know if that addressed your question, but it really depends on the conditions. And of course, you can then think about prevention, but that's a very difficult question altogether. In terms of the, so although I totally agree that we need to strengthen young people in how they cope with their emotions, for example, I also think that those people with diagnosable mental health conditions are suffering a great deal, are putting a huge burden on their families and or their societies, so they may also be supported with targeted treatments. And I'm very happy to talk to whoever wants to come into this area to think together about which treatments might work best for which conditions. Thank you.
Okay, I think we're coming to the first half of our meeting. Unfortunately, we cannot offer lunch as all these things. You know, we run a very low economy kind of initiative. There are lots of places where you can grab a sandwich around. Come back by 1. We've got a very exciting afternoon. You're going to hear about all our young researchers in a very quick succession, giving you their ideas. There will be plenty of other speakers, and we have a wonderful roundtable later in the afternoon. And we hope to hear from the editor of Lancet, Richard Horton, at the end, his reactions to what he's heard today. So see you all at 1. Thank you.